Welcome to the Dermalorian podcast from the Dermatology Education Foundation. The Dermalorian podcast is an independent program made possible with support from UCB. From diagnosis to staging to treatment selection and long-term monitoring, the management of hidradenitis suppurativa can seem daunting. But for the patients affected by this impactful disease, the proper treatment can be life-changing, says dermatology nurse practitioner Wendy Cantrell. Ahead, she provides an update on diagnosis and treatment options and discusses key considerations to support treatment access.
It goes very much in families, so it's just something that happens in a family that they didn't know, they're embarrassed by it. But it's thought to be a disorder of the terminal follicular epithelium in the apical gland-bearing skin, most often in the axilla, the groin, the inframammary, and I've seen it in the neck as well, and the lower back, as well as in patients that have a larger abdomen, it'll be in that pannus area as well. It is chronic, it's autoimmune. It can begin with like those open comedones, progresses to recurrent cysts, abscesses, scarring sinus tracts, and patients have so significant, they are in pain, they're embarrassed, they feel like they have an odor, and often they do. They think that they're infected. These patients are people who hop from urgent care to urgent care for their infections, and they're given antibiotics after antibiotics after antibiotics, and it just continues to recur. These are patients that oftentimes they don't think about seeing dermatology first. They're urgent care, they're OBGYNs, primary care, and oftentimes can be just on a cyclical, just practice of just not improving. So it is something that is very, I think that when adalimumab got the approval for HS, I think they did a really good job about talking about opening up that conversation, getting patients to understand that this is not normal in every family, that this is something that they do need to have treated. So it's very good that they've had, the conversation was open several years ago. We started seeing more and more referrals for HS into dermatology from GYNs, from primary care, even from urgent care. I get them pretty frequently from even urgent cares in my area. So Hurley staging is the staging that is used in clinical trials, but it's not one of the more cumbersome stagings like PASI, easy, salt, that kind of thing. It's pretty easy. I do include the Hurley staging in my notes. So stage 1 is a couple of abscesses, not seeing the scarring yet, not seeing the sinus tract. Stage 2 is recurrence, starting to see the scarring and the sinus tract, multiple locations, so not just one armpit, but other couple of locations. And then stage 3 is the worst, with multiple interconnected abscesses, large sinus tracts that just take up a whole plaque of skin. So treatment options. So at any stage, you're going to talk about pain management, mental health, wound care. These patients are depressed. These patients, especially the ones that have groin lesions, they are not comfortable dating. They're not comfortable with intimacy. This is a very important thing that we need to be talking with our patients. How are you feeling? These patients, there's a high suicidality and suicidal ideation and depression with these patients. And if we're glossing over that, then we are really missing the boat here. So there is some, a lot of times the first line treatment is going to be your tetracyclines. Not hugely. There's not a lot of great data that says that this is super effective. There is some good data on rifampin and clindamycin. So if you were going to start an oral medication first before you jumped off to a biologic, then that would probably be the one that I would recommend. The anti-TNFs, so that's going to be adalimumab. That is a great place to start. Infliximab also has some good data. You'd have to have, a referral site to. Very few dermatology sites anymore do IV infusions, but that is an option for that. There is some information on hormonal treatments. Female patients who are on birth control or spironolactone, if they notice a correlation with their cycle, sometimes they will, I'm not saying that it's going to be a cure, it's not going to be curative for them, but they might see some improvement. There is some data, not great data, but there is some data on isotretinoin. Acitretin, if they're not of childbearing potential, there is some data on that. Now we have secukinumab that is approved. We also have bimekizumab that is approved. There are some surgical options as well. I think we really want to try to move away from surgical options when we're just removing the entire Hurley stage 3 plaque, because patients are not being able to move their arms. They're having some issues with mobility because we're taking out that complete piece of skin, and it's not curative. Unfortunately, it's a really sad thing when they've had, these plaques removed from their arms, they can't raise their arms, and it still comes back. There's some interesting information on the YAG laser, the CO2 laser.
You're listening to the Dermalorian Podcast, an independent program made possible with support from UCB. We'll get back to the discussion of hidradenitis suppurativa momentarily, but first, in this episode's Dermalorian Derm Decoder, dermatology nurse practitioner and DEF president Joe Gorelick provides tips for making the most of Rosacea Awareness Month.
April in the United States is Rosacea Awareness Month. So remember, when you encounter patients with rosacea, don't overlook it. Talk to the patients about it and make sure they know there are multiple components to the disease. Figure out which ones bother them most and let them know that you have great therapeutics, topical, oral, that you can help them address their condition. We've got very effective therapeutic agents, more effective than we've ever had before to reduce the number of bumps. And we have 2 topical prescription agents that can help with the background pinkness. In addition, we have multiple oral agents that can help control this incredibly burdensome disease. So do your part. Do what you can for your patients with rosacea to help take this disease off their plates.
Let's get back to Wendy Cantrell as she addresses supportive care, patient counseling, and other critical considerations related to hidradenitis suppurativa care.
In all cases, we need to be making sure that they know how to keep their wounds clean, that they are cleansing themselves well. And I do tell my patients, if you get that one little red painful bump, whether you're on treatment or not, come on in. If you can jump into my clinic, and I'll tell my schedulers, if I have an HS patient that says that they need to come in for a steroid shot, and we'll do an intralesional Kenalog injection into that bump, that can often stop that from progressing. So making sure patients know that you're very willing and able to do that is important. So let's go over this case review. So this is a 57-year-old female, and she's in the office with a previous diagnosis of severe HS. She has it in 3 areas, so the groin, chest, and axilla. So what stage is she? 3, because she has it in multiple locations. She does feel like it's hormonally triggered. She's been treated with multiple courses of doxy, ILK. She failed adalimumab a couple of years ago. She saw another dermatologist, again, given doxy and spironolactone. And she is saying that she is 8 out of 10 pain. So not a lot of improvement. Discontinued spironolactone because she was lightheaded. Don't you love it when that happens and they don't call you? They just decide. And so it was offered to be in a JAK study, but declined. There are JAK studies being done for HS. The initial data looks really good. So keep that in mind. And we decided to start secukinumab. She was given the first dose in the office, and she was given the first 5 doses to take home and to inject weekly as our biologic coordinators were working tirelessly. She's not in here anymore. Tirelessly to help us get that approved. She felt like she had more good days than bad days when she followed up. But things were still, there were still lesions in her wound, weeping in her groin. We started Silvadene, which is a great product to use for chronic wounds, and then a follow up. At week 4, she had a setback. She felt like she was flaring again. Physical examinations, we thought that she had improved some, but did have some flaring lesions in the groin. We did ILK and continued secukinumab. At visit 5, she had COVID. Rains it pours, right? She had COVID, so we held the dose for a couple of weeks with no significant flares. Things were starting to heal, less drainage. In week 6, best than her skin had been in years, no drainage for about a month, and she had to stop wearing those gauze pads that you had to stuff in there. And pain level was a 2 out of 10. The hard conversation with patients about HS is, unfortunately, right now we don't have a cure. I don't have a drug that I can say 60% of patients have no lesions at 16 weeks. We don't have that yet. Now, there's lots of clinical trials not just with the JAKs, but with other small molecules that look very, very promising. The bimekizumab data is very good as well. But to have to sit in front of your patient and say, my wish for you, if I had a magic wand, is that I could clear you up. But my goal for you is to decrease the number of lesions that you have per month and to shorten their severity, shorten how much they are bothering you. That's not what I like, right? I like the PASI 100s and the EASY 100s and the SALT scores of 0. And I love when we're able to fix a patient, and we're not there with HS. Now, we've moved farther to it, and patients are seeing improved quality of life. People are talking about HS, and we should talk to our colleagues that refer to us about HS as well, and make sure that they're not just throwing the antibiotics at them for years and years and years. There is a lot of data that shows that if we start a treatment sooner, so if we start the treatment at Hurley 1, that maybe we can prevent them going to Hurley 3. And so that is something that I think is really important for us to have a very short threshold to where we're going to start a systemic medication.
Now it's time for this episode's Dermalorian clinical clip. Do you have patients that are frustrated with itch? Are you frustrated too? Don't fret. The itch and rash whisperer, dermatologist Dr. Jenny Murase, has tips to better manage this common complaint.
I think that the first pointer in terms of approaching a patient with itch would be to remember to ask about the itch. And you can do that through a simple question, developing an NRS score. It's called a numerical rating scale, where you say on a scale of 0 to 10, in the past 24 hours, what is the worst itch you've had, if 10 is the worst itch imaginable. And that gives you a sense if you're dealing with an itch of 1 or you're dealing with an itch of 10, right? And it's only the patient experience because the itch is invisible. The second thing that's important to ask, and you can ask this very quickly, is it disrupting you from your sleep at night? So if they say yes to that, usually their NRS will fall between about an 8 to 10 out of 0 to 10. And then you can ask, is it distracting from activities during the day? Because that's going to get you to about a 4 to 7 on 0 to 10 if you ask those two questions. And you can ask those questions fairly quickly to get an assessment for the itch. I think that the other critical thing to remember is to look to see if they have a lot of mast cell degranulation. And you can do that through a very simple test. You take a tongue blade and you do X marks the spot on the back. And if pressure is applied and it welts up and it becomes bright red, or if it develops a white color, we call that red dermatographia or white dermatographia, because dermatographia means to write on the skin. Well, then you know that they have a high mast cell load. So you're going to be thinking about medications, like antihistamines, for example, that would decrease the mast cell load. And that will help to provide them with relief from their pruritus, so that they get relief from that recalcitrant itch that they're experiencing. The other thing that's very important is to make sure that you're looking for, using all the diagnostic testing that we have available, looking for potential reasons for the underlying itch, particularly if it's a patient that has very little to see on the skin. So you want to be afraid, very afraid, of the 20-year-old, the 30-year-old patient that's extremely itchy and there's very little to see on the skin, because that could be the one symptom that they have for lymphoma or leukemia. So it's helpful, for example, to do a chest x-ray to look for Hodgkin's lymphoma. It's helpful to do a manual CBC, which is a complete blood count, or a CBC with a differential, so that you can look to see if they have leukemia. And you can also do blood flow cytometry to look for leukemia and lymphoma and do a panel to look for that and screen for that. Or for that matter, looking at their creatinine to see if they may have renal insufficiency, doing a hemoglobin A1C to look for diabetes. These are all things that are going to predispose to neuropathies. So there are set labs that are good to order in patients with very recalcitrant itch that have very little to see on the skin.
You can get more from Dr. Murase in the Dermalorian webinar series, Itch and Rash Whisperer Virtual Grand Rounds. The next live presentation is in June. Details on this and all DEF programs, including the DEF Essential Resource Meeting 2025 or DERM 2025 NPPA CME Conference, are available at dermnppa.org. Thanks for listening to the Dermalorian Podcast. If you like what you're hearing, share it with a colleague.